Good afternoon, everybody. My name is Dr. Dennis Goodman. I'm a clinical professor at NYU in the Department of Cardiology and Preventative Cardiology. I'm also the Director of Integrative Medicine at NYU, and I want to welcome you to the Heart Health Lecture Series, which we put on. As you know, we've been doing this for several years, since 2015, and we're very proud of this series, and we are delighted that you're joining us tonight for what is going to be an outstanding talk. Next slide. Next slide. So if you have a question, we've already received several questions for tonight's talk, but if you have one and you go to the Q&A box, I think you've all become familiar with that. You can ask a question anytime during the talk, and I will try my best to field everybody's questions. And if they aren't answered tonight, next slide, then I will add them to a list of questions that we're now collecting for our next talk, which is going to be a casual conversation about cardiovascular health. I've found several of our colleagues, experts in the field of cardiology. We're going to try something different. We're going to have a conversation, an armchair conversation where we'll take questions and we'll just answer every aspect of cardiology, anything you're interested in. If there's something on your mind, please send us your questions, and I will, again, field as many as possible. So that's Tuesday, March 22nd, between 5 and 6 p.m. And then in April, we're going to do how food choices affect the environment. Should be really fascinating. So put that on your calendar, April 11th, 5 to 6 p.m. To register for these programs, the email address is nyulangone.org/hearthealthlectures. And that's also a site where you'll be able to send us any information that you have or anything you're interested in, and you can give me feedback about these lectures. Next slide. So we've had many topics over the years. We're actually up to about 50 lectures right now. And as many of you have attended, you know, and have heard several of these topics, including the microbiome, sleep, prediabetes, treatment of diabetes, aspirin, stress, thyroid disorders, inflammation, CBD oil. I always say that preventative medicine is all about the four legs of the stool, and that's how I think about every single patient that I see, and that is to think about what are the most important things for preventative medicine to be healthy. And number one is to eat a healthy diet. Number two is exercise and flexibility. Number three is good sleep, healthy sleep. And number four is stress management. So all my lectures revolve around these topics in one way or another. And if you have any particular topic that you'd like me to focus on, please let me know. And I'll do my best to get us a fantastic speaker like we always have. Next slide. So this is something that we've had for the last few months, which I'm really proud of. We have a lecture library. You can actually see our lectures on YouTube, and you can just go to the NYU Langone's YouTube channel. So the address that I gave you, I'll show you again in a minute, and you can use the link to get to the YouTube, where all our lectures that have been recorded are up. So if you missed one, or you've got a colleague or a friend that would like to hear one of our fantastic lectures, you can hear it on YouTube. Next slide. So here are our addresses for us. There's the website that I already gave you. There's the email address, hearthealth@nyulangone.org. We also have our Twitter account at NYUCVDPprevent. Next slide. So this is the address that I think you should write down because you've got all the information you need, nyulangone.org/hearthealthlectures. Next slide. So I'm very, very pleased to welcome and introduce a fantastic speaker for tonight's program. And the reason we have Dr. Reynolds on is that we're celebrating American Heart Health Month and the American Heart Association's Go Red for Women, with a special webinar dedicated to raising awareness about the issues that are unique to women and heart disease. As you can see, I'm wearing my red reading glasses, which is one of the important things that we all do, just to wear red or to think about red during February, because it just focuses on the importance of women and heart health. Dr. Reynolds is our speaker tonight. She was tied up with an urgent problem with a patient, and I hope she'll be with us very soon. But in the meantime, I'd like to introduce her. She's one of our favorite speakers. She's been on several times, and we really are honored that she's joining us tonight. She did her training at medical school at NYU School of Medicine, and also completed internal medicine and cardiology at NYU and Bellevue Hospital. She's Associate Professor of Medicine at the NYU Grossman School of Medicine, where she directs the Sarah Ross Sotter Center for Women's Cardiovascular Research and is Associate Director of the Cardiovascular Clinical Research Center. Dr. Reynolds' research career has been focused on mechanisms and outcomes of cardiovascular disease in women and testing of treatment strategies for ischemic heart disease in clinical trials. She's particularly well known for her work in myocardial infarction with non-obstructive coronary arteries, MINOCA, and stable ischemic heart disease with non-obstructive coronary artery disease. I know you're sitting and saying, what's all that about? But you're going to find out in the lecture very shortly. Dr. Reynolds is the Associate Director of the Clinical Coordinating Center for the NHLBI-funded International Multi-Center Ischemia Trial. In addition, she was the Principal Investigator of the CHOW Ischemia Study, an international multi-center NIH-funded study researching the relationship between changes in symptoms and changes in stress tests over time in patients with INOCA. She worked with colleagues to report on the relationship between medications and COVID-19 diagnosis and outcomes, and the role of microvascular and macrovascular thrombosis in severe or fatal COVID-19, leveraging extensive experience at the NYU Langone Health System in New York City, an early epicenter of the epidemic. Dr. Reynolds' clinical efforts include general cardiology practice at NYU with a focus on cardiovascular disease in women and supervision of the fellows in the Bellevue Hospital Cardiology Clinic. Dr. Reynolds was named an AHA Founders Affiliate Rockstar of Research in 2011. She actually is a rock star at NYU, remains one, and always will be one. We are very honored to have her. I'm delighted to have her as a colleague. We're so proud to have her in the NYU Department of Cardiology. And I hope Dr. Reynolds has managed to get online with us because she's been tied up in the office. But I'm hoping you're there, Harmony, and welcome to our program tonight.
I sure am. Thanks so much for having me.
Thank you so much. I'm sure you had a little bit of stress and you needed stress management, but we can also give you that if you need it, because we're very focused on preventative medicine, not only for our patients, but also for our colleagues and friends. So welcome, Harmony, and thank you so much. I know you talk quickly, so I'm sure you'll get through your lecture. Don't rush and stress, because we can take some of these questions in our next month's program if you don't get to the questions tonight.
Well, thank you kindly for that. Thank you for trying to relieve my stress, Dr. Goodman, my treasured colleague. I thought that, as you've said, and for the folks on the line, I do speak pretty quickly. I'm a born New Yorker, and I tend to go pretty quickly. Plus, there's so much wonderful information that I want to share with you tonight. So I'll go through it pretty fast, but we'll cover a lot of ground, and hopefully you'll learn a thing or two. Anya would go to the next slide, please. We will cover some statistics you should know, what heart pain might feel like and what the causes are, what testing is best for people with possible cardiac symptoms, how we can prevent heart attack and stroke and death from heart disease, and what to do if you or someone else might be having a heart attack or stroke. Next. Cardiac disease is the leading killer of women and men. This has been true for a long time. It hasn't changed, and it's not likely to change soon. So you can see this is from the Centers for Disease Control, and these are the data from 2017, but it's been true year after year. Heart disease is the leading killer of women and men, and stroke, as you can see, is high up on this list as well. It's true in every race and ethnic group. Next. Death rates from cardiovascular disease are on the rise again. As we look at this trends graph from 1980 to 2020, we can see that women in red had for a period of time a higher rate of cardiovascular death, more cardiovascular deaths even than men. And there was a big gender gap that we worked to address. And we've gotten somewhere, but after 2010, the rate of death from cardiovascular disease is on a rise, and this is not something that we want to see. The rate in women's a little lower than men, so yay. Nobody's too excited about seeing an upward trend here. Next, please. Unfortunately, the knowledge gap is huge. The American Heart Association does routine surveys of women to understand their attitudes and their knowledge base about heart disease. This graph shows the simple question that women were asked: what is the leading cause of death for women? You can see that in 2009, about 2/3 of women got it right, that it was heart disease, or even they might said heart attack. And then you can see that in 2019, this went way down, so that now more than half of women got it wrong. And why is that important? It's important because if we don't recognize heart disease as our threat, we might not do everything possible that we can to address it. And when Anya clicks the mouse again, you'll see that these trends were the same across every race and ethnic group, was even worse in our younger women. So what's going to happen to the next generation when they get heart disease? I'm worried that they're just not going to know. Next. So with this in mind, you are a champion for women's heart health. Thank you for attending this lecture. Please share whatever knowledge you've gained today with your friends and your family and your colleagues and anybody who might need to know, because there's a lot of people out there who just don't know. Next, please. All right, now we're going to talk about chest pain. And there were some chest pain guidelines that came out this year that are helpful for doctors, and I think there's helpful information for patients in here as well. On the next slide, we'll start by just talking about what do doctors mean by chest pain. And it's really not always pain, and it's not always in the chest. So this may be a little confusing, because if your doctor asks, are you having chest pain, and you're instead feeling something that's a little uncomfortable, and it's sort of off to the side, or maybe it's in a shoulder, you might not know how to answer. And the easy answer is, yes, I think so. Because when we're looking, you see this outlined in red, when we're thinking about symptoms that may be heart-related, those can be anywhere in the upper body, in the jaw, the neck, either shoulder, either arm, the chest, the back, the upper abdomen. The upper stomach is a common area for chest discomfort too, or for heart discomfort. We will often, I try my best to ask about any discomfort in the upper body, because I want to catch everything. But sometimes even I fall into the shorthand of asking people if what they have is chest pain. So even if that's something that you're feeling something that's a discomfort that's somewhere in the upper body, if we're asking you about chest pain, just explain what it is you're feeling so that we can use our best diagnostics to sort that out. So it's chest pain, but it might not be pain, and it might not be in the chest. Next. Common question: do women and men really have different symptoms of heart disease? Because if it's so different, how are we supposed to know what women are feeling? And the short answer is no. Men and women have very similar symptoms of heart disease. There are some subtle differences, but again, they're subtle. And in general, most heart disease is going to be felt somewhere in the upper body as a discomfort. That's true for men, and it's true for women too. Next slide. It is true that women are statistically less likely to feel chest pain or report chest pain when they have heart attack. This study shows us over 1 million patients with heart attack, women and men. And we can see two things. The women on the left, their likelihood of coming into the hospital with a heart attack but not having chest pain with that heart attack is just a little higher than in the men. But as you can probably appreciate here, looking at these graphs ordered from youngest to oldest, going left to right, the impact of age here is much bigger. So it's older women and men who are less likely to have chest pain, even if they're having a heart attack. We have to be vigilant about all different symptoms that might be related to heart attack anywhere in the upper body. But the difference between men and women is just not that big. Next slide. If most women have chest discomfort as a heart attack symptom, then what's all the fuss about differences between women and men? Now, I've given this a lot of thought, and I think that studies show us that the description of symptoms is less uniform from woman to woman and man to man, and I certainly experienced this in my clinical practice. Just like, the cliche is, if a woman's describing a color, the woman might say, well, it's sort of a peach shade, it's a coral, and a man might say, I don't know, it's pink, it's orange, I'm not sure. But the description may be a little more subtle and a little more variable from woman to woman, even if those two women might be feeling what is probably the same thing. Doctors tend to rely on pattern recognition. It's the way that we're trained. So we're listening for that thing that sounds like chest pain. Women are also more likely to have additional symptoms like shortness of breath or nausea or sweating when they're having a heart complaint. And so we need to make sure that doctors are thinking about all of this as a constellation, a group of symptoms, and not just one thing. I also find that women tend to offer their own explanation for their symptoms. They tend to downplay and apologize. I'm so sorry that I'm bothering you with this. I think it might be heartburn. I did have something funny. Don't start explaining away your symptoms. Let the doctor decide what it is. You're much better off saying, doctor, could this be my heart? I think sometimes people are afraid of the answer. Don't be afraid. Heart disease is preventable, but it's also treatable. If it's heart disease, we'll deal with it. We'll help you through it. Most likely thing is you'll survive and you'll feel fine, but we need to get you through that. And minimizing and saying, well, I'm not sure. I don't know if I should bother the hospital with this. That's not helpful. So try and be as direct as you can. And you bring up, you're coming in worried this is your heart. So go ahead and say so. Next. There are two types of patients with chest pain. When physicians think about chest pain patients, or again, any upper body discomfort, we separate in our minds those stable patients who are walking around, may experience their symptom with emotional stress or physical stress, but it's not lasting a long time, and unstable patients, those who are having their symptom for no apparent reason, without a warning, and it's lasting more than 15 minutes. Those are those patients we're worried about heart attack in. Last year, I focused quite a bit on the unstable patients, the heart attack patient. This year, I'm going to focus more on the stable patient, though we will get into heart attack a little bit. Next. These chest pain guidelines, again, very comprehensive and really useful. And one of the first things they say is not everybody with stable chest pain needs a test. And the doctors listening to you, making a diagnosis using the EKG, for example, and examining you, that may be enough to say, you know what, this is not a heart thing. And that's wonderful. You don't then need a test. But it's always important to take the time to think about heart disease risk and prevention, because even if it wasn't heart disease now, we don't want it to be heart disease later on. So even if your doctor says, oh no, that's clearly your muscles and bones, I'm not worried about it. Okay, but let's have a conversation about what your risk factors for heart disease are and what you and your doctor can do to reduce that risk. Next. There are many tests available, and one of the biggest advances has been coronary CT angiography, and the chest pain guidelines really focus on CT as the first test for most patients. That's a big difference. Many of you may have been accustomed to thinking that the first test would be a stress test if you're having chest discomfort or another person's coming into a doctor's office with a heart worry. But it turns out that CT scans, as I'll show you, may wind up being the best first test for many patients. But neither test is perfect. I'd love to have the perfect test that gives me both the information from the CT and the information from the stress test, but we're not there yet. CT scans show us plaque. They give us, and I'll show you some examples. We're going to give you a visual of the artery, tell you what any plaque narrowing might be. It's 50% here, it's 20% there, or just that there's hardening of the arteries. But they don't say for sure if your symptoms are coming from the heart. And that is an important distinction, because lots of people have plaque that's just lurking there waiting to cause problems, but it may not be causing the symptoms somebody is coming into the office with right now. You can imagine that somebody who has a lot of heart disease might walk around, break their ankle. Nobody thinks that broken ankle is related to the plaque, and the same can be true for chest discomfort. On the flip side, stress tests can tell if symptoms are from a blood flow problem, but they're really only able to detect narrowing that is 80% or greater in general. So there are plenty of people with a normal stress test who still have plaque. And I've said for a long time, normal stress test is not a clean bill of health, because you can have a lot of plaque lurking in the background that can still be dangerous and can lead to an increased risk of heart attack or death. Here are the two types of CAT scans that people will get. On the left is the CT calcium score, sometimes said as CAC or CAC. This is a more limited scan. It uses less x-rays. It's inexpensive. It's usually out-of-pocket payment, but it's somewhere between $100 and $150. It only finds hardened plaque. And I'm not sure if you guys can see my mouse, but hopefully you can see over here these white blobs that are coming here, that you can imagine them tracing a line. And that is an artery that has hardening. This is sort of the old school thing we used to say, hardening of the arteries. And the CT calcium test will find that. It will give a score. You can look up how you scored compared to other women or men of your age and race. And then this time, you don't want to get a high number. You want to get a low number. I've got less plaque than everybody else my age. That's what you're looking for. But if you've got a high number, that means that we have too much high risk. This doesn't tell us what percent the arteries are narrowed. And so it can't tell us if chest discomfort is coming from arteries. This is used only as a risk assessment tool. On the right, we see a CT angiogram. This one shows us, and hopefully you can see my mouse here, you can see this artery coming down. You see all its little branches. I see that it's nice and smooth and even. I see this other artery that's coming around. It looks even bigger than that one. So we see them in beautiful detail. The radiation exposure, X-ray exposure for this is similar to a nuclear stress test. Sometimes it's even lower. This has the advantage of finding both hardened and soft plaque. And it's better if I need to know the percent arteries are narrowed, because it will give me a better sense of whether chest discomfort might be related to heart disease, even though this too may not be definitive. Next slide. When we're thinking about testing, the latest word in research is to not just ask, what can the test show us, but to ask, what will the test do for my patient in terms of prevention? And we have two recent studies that have put these two tests head to head, stress testing and CAT scans, to see if we can reduce the risk of death or heart attack in patients with suspected heart disease. And for those of you who might not have been through one of these tests before, on the left, you can see that's Megan Kelly when she had her stress test. You see she's walking on a treadmill. She's being observed by medical personnel. There's an EKG there, and there's a table next to her so she can have some imaging tests to go along with that stress test. She's going to exercise on the treadmill, and then we're going to get some scans of her heart. And on the right is a CAT scan, very different. You're not exercising. One is lying on a table. It goes through this donut-shaped thing. It's a very fast test. You just hold your breath and it's over, but there's no exercise involved in that. Next. When these two tests really have been put head-to-head, studies show that the CAT scan may be better. When patients in this study, it's over 4,000 patients, and they were randomly assigned to get standard care, which was generally a stress test, plus that CT angiogram, or standard care alone, which generally, again, included an exercise test. And we can see that the rate of death from coronary heart disease or a heart attack that wasn't fatal was lower in the people who had the CAT scan. So we may find that this testing strategy could even prevent heart attack and save lives. And on the next slide, we'll think about why that is. In this study, there was more medical treatment in the CT assigned group. Now we think, working backwards, that's because the CAT scan is showing us not only the very severe narrowings, but also those milder narrowings that still put us at risk. And in response to seeing that plaque, doctors were prescribing medications and patients were taking them. And that's probably the difference. And this is why I am now leaning more towards CAT scans as my first test. An additional study called PROMISE also put CAT scan and stress testing head to head and showed no difference. Overall, the PROMISE group was at lower risk than this study called SCOT-HEART. Next. Now, who can't get a CT angiogram? I've just told you of all the benefits of a CT angiogram. Who shouldn't be getting it? And you know what, Ani, if you don't mind clicking a couple times, I'm not sure, I didn't know that flow diagram was animated. The chest pain guidelines, one more, will show you that if you have stable chest discomfort and no known heart disease, we do a clinical risk assessment. If you're real low risk, if your doctor doesn't even think this is heart disease to begin with, you don't get a test. But if you're at intermediate or high risk, the guidelines show that either of these tests is considered appropriate. I tend to favor CAT scan for the reasons I just showed you, but you can't get it if you're allergic to contrast liquid. You could, but it might not be the best first test for you. You'd need some pre-medication to prevent allergy. If you can't hold your breath, if you just absolutely can't hold your breath, if you have kidney disease, that might put you at higher risk of getting the liquid contrast, or if you can't take the two medicines that are typically given during this test, slow the pulse and open the arteries. Those are beta blockers and nitroglycerin. Or if your heart rate just happens to be so variable, for example, because you are constantly in atrial fibrillation, that the heart we won't be able to get a good picture because the heart's moving around too much. Also, it's good to know that the CT is focused on the heart, but some parts of the lungs or the breasts or even the upper belly may be seen, and any findings will be reported to you and your doctor. Next slide. Let's play out how the CT first strategy works, because when I am selecting a test for my patient and discussing this, I try to think 3 steps ahead, like somebody playing chess. If I get this result, what am I going to do? If I get that result, what am I going to do? Because I want to make sure that I'm prepared for the next step, no matter what this result is going to be. If the CT shows no plaque, or plaque that's not blocking the arteries even halfway, then we say that the chest discomfort is either not from the heart, or it is from the heart, but it's one of these small vessel things or spasm things, and we're going to talk more about that later. In this case, medical treatment and lifestyle measures are needed for prevention, then we can stop there. If there's at least 50% narrowing, we may still not be sure if the chest pain was due to heart disease, and so we may ask for a stress test in this situation. If you pass the stress test, we say medications and lifestyle measures are enough. If the stress test is positive, then stents and surgery might be added, but surprisingly, they might not be necessary anyway, and I'll tell you some more of the research behind that. Next. Now let's think about the stress test first strategy. If the stress test is normal, it's negative, then the symptoms probably weren't coming from the heart if the test quality was good. How do you know if your test was good? If you exercised and didn't have a chemical stress test, but instead you walked, let's say, on a treadmill, then we'd want to see that your heart rate went up to 85% of what's predicted for your age. If not, you might be asked to redo that as a chemical stress test or have a CAT scan, or your doctor and you might think about whether you really do need a test at all. No matter what, even if the stress test is negative, you need to have a prevention discussion. You're going to hear me say this over and over again because we really believe in prevention for heart disease. It works. Next. Now let's say the stress test is positive. This is the more feared outcome. Well, now what? Then artery narrowing from plaque is likely, but it's not definitely present. Stress tests aren't perfect either. We definitely want to do all of the guideline-directed preventive therapy. We would use aspirin here. We would use statin to reach an LDL cholesterol that's between 30 and 70 in general. And we'd want to use medication that will treat the discomfort since we think it's heart pain. And we'll want to use lifestyle measures. I'm a big proponent of the Mediterranean diet. It's important to do at least moderate intensity exercise 6 days a week or more. Stents and surgery may be useful depending on how bothersome the symptoms are and how many arteries are narrowed. Next. We actually studied this at NYU. What do we do with somebody who really flunks their stress test and has artery narrowing? This was called the ischemia trial. It was a government-funded, a very large global study that was led at NYU. We started with patients who had a moderately or severely abnormal stress test. They definitely flunked. And a CAT scan showed that they had artery narrowing. But the patient didn't know the details of whether it was 60% here or 80% there, and neither did the doctor. These patients were randomly assigned to a conservative strategy in which they got the best available medications and did lifestyle measures, but did not have a conventional invasive angiogram and didn't get stents or surgery unless they had persistent ongoing chest discomfort or had a heart attack. Or they got randomized to a routinely invasive strategy in which all of the best medicines and lifestyle things were still used, but those patients had an angiogram and had either stents or bypass surgery to open or bypass all of the narrowings. What are the results? We're going to see them on the next slide. These are the main results of the ischemia trial, and I'm showing you the medical graph here because I think that you guys are perfectly able to assimilate all this information. So on this x-axis going to the right, we have time in years. And going up the vertical axis, we have the percentage of having a bad heart event: death, heart attack, unstable angina, which is sort of a milder form of heart attack, heart failure, or resuscitated cardiac arrest. The red is the patients who routinely got stents or surgery, and the blue is the patients who are treated conservatively. And we can see that by 6 months, 2 out of 100 more patients had one of these bad events with the invasive strategy. That rate about equalized around 2 years. And then when we went out to 4 years, 2 in 100 patients were less likely to have one of these bad events if they were treated in the invasive strategy. So what does this mean? The first thing is it wasn't a big difference. So people can choose which thing they want. For most patients, it's not a requirement to have stents or surgery as we used to think many years ago. The other thing here is that there's an upfront cost of risk from these procedures, but there may be a long-term benefit looking out to at least 4 years. The patients who were randomized to the conservative strategy could have stents or surgery if they had a reason for it. So it was sort of a conservative initial strategy. And almost a quarter of them ultimately had stents or surgery anyway. Next. There was absolutely no difference in survival whether we started with a routine invasive strategy of stents and surgery or medicines and lifestyle alone. Next. If we looked carefully at the patients who had the most plaque versus a little less or a little less or a little less, we can see that this group on the upper left that had severe narrowing in all 3 arteries did seem to do better with a routine invasive strategy. But most patients were not in this group. This was a small subgroup. And even in this small subgroup, life was not extended by the routine invasive strategy. Next slide. We also did a parallel study in patients with chronic kidney disease, because in chronic kidney disease, we worry about protecting the kidneys and protecting the heart. There was no difference in the rate of death or heart attack with the invasive strategy or the conservative strategy, but there was more dialysis in the invasive strategy. Next. So putting this all together, it seems that stents and surgery may not be needed for blocked arteries. And that really has, now we have to walk it all the way back to the person who's first showing up to the doctor with chest discomfort. And we have to think 3 steps ahead and know that most of these patients don't need stents or surgery. So as we look for narrowing, we're looking for an explanation. But this is not a knee-jerk response to put in stents or do surgery. Stents and surgery are still there if people are having ongoing discomfort that medications can't stabilize. But in general, our medical therapy does stabilize plaques, makes people feel better, and it prevents the dangerous events. Next. Then we have to get back to, why are these stents and surgery not doing the whole job here? And we have to understand then what causes heart attack and stroke in the first place. I'm going to show you a number of different slides to get at these points. Here we're seeing an artery, and let's say it's a heart artery. The blood is flowing along this blue arrow. And we have a plaque. It's got cholesterol and inflammatory cells, and it's there in the wall of the artery. It's narrowing the artery a little, but there's plenty of room for the blood to flow, and people can have these plaques and have no idea. And then, for reasons that we don't always understand, that plaque has a little cap on it that ruptures. And when that happens, the flowing blood can clot on it. That will close the artery, and that's what causes heart attack. If the same thing happens in a brain artery, it will cause a stroke. The most common cause of heart attack and stroke is artery narrowing from plaque with blood clotting. Next. But then let's go even earlier. How does cholesterol plaque build up? Well, we're born with normal arteries, and we can imagine that the blood is flowing through here. But over time, as we eat an unhealthy diet especially, we build up a little plaque, and the artery tends to enlarge to accommodate that plaque so that there's plenty of room for blood to flow. It's only in the very late stages that the plaque will build up enough to block the artery. Next. Small plaques are very common, and they're potentially dangerous. They start to show up even in the late teens and the 20s. Most heart attack starts in small and medium plaques, and many people have more than one of them. Not all small plaques are dangerous, but some are. Some of them are called vulnerable, and there's a tremendous amount of research going on at NYU and elsewhere to try and sort out which plaques are vulnerable, how to pick them out, and what to do about it. So when we think about arteries, then, we have to reconsider what we're trying to fix. For many years, the idea was that this rusty pipe idea, that if an artery is narrow, then we need to open it. I've got blocked pipes, just root out the bad stuff and I'll be fine. But in reality, most of the plaques that cause heart attack and stroke are not badly blocking the artery, and we can't make them go away. Instead, we want to change them on a microscopic level to be safer. The analogy I like to use is that of a raw egg. An egg has a bunch of gooey stuff inside, kind of like a plaque, and it's got a thin shell, and plaques have thin shells too. If the shell breaks, it's like this rupturing of the fibrous cap that I showed you in the previous more medical diagram, and the stuff oozes out, the flowing blood is exposed to it, and it can clot, makes a big mess. But on the next slide, we'll see what happens when we use diet and lifestyle measures, exercise, etc. Well, we change this on a microscopic level. It's a lot like hard boiling an egg. The plaque is not any smaller, but it's a lot safer, and it's totally different inside, not as fragile. So from a medical standpoint, we talk about having a big lipid pool, a big pool of grease in the middle there with lots of inflammation in that artery and a thin shell, a thin cap over that plaque. And with treatment, we get less grease inside that plaque, inflammation is calmed, and there's a thicker, safer cap over the plaque. So that is a lot of the point of the diet changes that we ask for, cholesterol lowering medication and exercise, to try and get this to be more stable. Next. Most patients with abnormal CAT scans or stress tests are treated medically, but stents and bypass surgery are still helpful. I don't want to leave you thinking that they're useless. They're still helpful for people who have symptoms that are bothering them after medication and lifestyle measures. They're helpful for specific types of narrowing. If the narrowing is in the main artery on the left side, we generally think surgery is warranted for that. when all the arteries are badly blocked, as in that group with the most severe plaque that I showed you. We think that probably stents and surgery are useful. And I've been talking to you all along about stable patients coming from home, maybe having chest discomfort when they walk, it's relieved when they calm down, having chest discomfort when arguing with somebody, it calms down when that argument is over. That's a different situation than a heart attack. In heart attack patients, stents and surgery are critically important. Next. Now let's talk about causes of chest pain that are cardiac pain other than plaque buildup. And we're going to be talking about something that's now called INOCA. Used to be called cardiac syndrome X, like this very mysterious thing that happens to women, or microvascular coronary disease. But the current term is INOCA, ischemia with no obstructed coronary arteries. Next slide. You can have heart symptoms without any plaque or without a lot of plaque, and these are the main two causes. One is coronary artery spasm. All arteries have a muscle lining, and that muscle can go into a cramp like any other muscle and temporarily narrow or even close the artery. That can go on long enough to cause chest discomfort or even to cause a heart attack. The treatment of coronary artery spasm may be different than that for plaque. We use medications that relax the blood vessel walls. The other thing that happens is microvascular coronary disease. This image is showing you all of the arteries of the heart. And when we usually show you arteries, we just show you the big ones. And those are the ones cardiologists think about the most. But those branch and get smaller and smaller and smaller to feed every little area of the heart. And you can think of it almost like a tree. You might focus on the trunk and the big branches, but the real action is where the tiny twigs and the leaves are. That's what keeps the tree going. In some people, these little blood vessels are not doing their job of regulating blood flow properly. We need a certain amount of blood flow when we're calm and relaxed, but we need a lot more blood flow when we're active or upset. And these little blood vessels are the ones in control of how much blood flows into the heart muscle. Sometimes they don't respond the way they're supposed to. In order to find one of these two things, we need specialized testing. And this is something that I'm really proud to say that we offer at NYU. A patient comes in here with chest discomfort and goes, let's say, to an angiogram lab. We're going to do all the testing that you need in order to come out with an answer, not just what it isn't, but also what it is. And that is a huge advance. NYU has multiple cutting-edge technologies. Some of them are invasive, some of them are non-invasive, in order to make the right diagnosis for patients with chest pain. And when we consider that it's women who primarily are the ones having these less common causes of chest pain, the things that are not all about plaque, we know that we're providing the best possible care that we can for women when we offer these tests. Next slide. What exactly am I talking about? Well, the non-invasive testing is PET cardiac MRI stress testing. In this stress test, the medication is given to increase blood flow. It's not an exercise test. And what makes this unique is that not only do we say, well, there's a little more blood flow here, a little less there. That's how regular stress testing works. Here, it's the precise amount of blood flow. We can tell you exactly how many milliliters of blood are going to the heart for every gram of heart muscle in every minute. And that's before and after the medication. As I was telling you, we have a certain amount of blood flow we need at rest, and then we want to be able to increase. We should be able to increase 3 times, 4 times, 6 times the amount of blood flow that goes to the heart. And this will tell us exactly how much that coronary flow reserve is. So it's checking for the small vessel problem in which the small vessels are not regulating blood flow the way that we want. And then we have invasive testing. The non-invasive testing doesn't tell us about the coronary spasm problem, but it's great for microvascular coronary disease. If we do invasive testing as part of a cardiac catheterization or coronary angiogram, we give 2 different medicines that are supposed to help the arteries bring more blood to the heart. More blood flow is expected, but sometimes we don't get the increase in blood flow that we're expecting, or we might even get a decrease in blood flow by inducing a spasm. So this is checking for coronary artery spasm and microvascular coronary disease. They call it coronary reactivity testing. This is something, again, that I'm very proud that we have at NYU. It really is only available at specialized centers. We do research on this. We do research on INOCA, and we're testing how blood platelet function, the cells that help the blood clot, how blood metabolites, and how our genes are related to the diagnosis, the specific diagnosis of spasm or microvascular disease, or both, or none, in patients with chest pain. We're testing how inflammation around arteries may be related to the various types of INOCA. Could we in the future do a CAT scan to figure this out instead of the tests I just told you about? We're also planning clinical trials, and we've done some clinical trials, watching measurements of stress testing over time in these women. So this is an exciting time for INOCA research, and I'm happy to be a part of it. Next. I promised I would talk about heart attack and stroke because I just can't do this type of lecture without making sure that you know exactly what to do if you or someone around you is having symptoms of heart attack or stroke. Early treatment works best. How do we survive a heart attack? Well, you don't wait more than 5 minutes for calling for help. People say, really, 5 minutes? Yeah, why not? You know, you have to call 911. They have to come. They have to get you to the hospital. And time is heart muscle. So, you know, if you wait an hour, you could be losing heart muscle in that time. The right way is to call 911 and get emergency medical services. Get to a hospital right away. You would not drive yourself because this is where we get into problems with accidents. And you might feel, well, you know, I'll just take a risk on it. I'm taking my life in my hands. But if you're on the road, you're taking everybody's life into your hands. So if you are having heart symptoms, do not drive yourself. And if you click on me again, I think I make that point in words too. I want you to learn the warning signs. We're going to go over them, and we've gone over them a little bit already. If you're not sure about your symptoms, please go to the hospital and let a doctor decide. Next. Do not drive yourself. I think I said that pretty clearly. Okay, next. Waiting it out is a bad idea. Everybody's heard a horror story of somebody who went to the internet and wanted to search chest pain, and then something terrible happens. Please do not do that. Go and get medical attention. Do not be your own doctor. Next. So what then are the symptoms? On the right, you see these images, what a heart attack feels like to a woman. Conveniently, it's exactly what a heart attack may feel like to a man. Some heart attacks are sudden and intense, but most of them start slowly with mild pain or even discomfort, and with one or more of these symptoms. Chest pain or discomfort. How do you know? Well, go back. It's going to be something that you haven't felt before, or if you felt it before, it hasn't lasted this long. What I'll sometimes say to people is, you know, if you eat sausage and pepper hero, which I don't want you to eat, but if you eat that and then you get terrible heartburn, but that meal always gives you heartburn, then of course we're not thinking that's a heart attack. But if you were having that for the first time ever, you might not know what it is, and it would be appropriate to go to the hospital and get that checked out. Remember that the discomfort can be anywhere in the upper body. There may be trouble with breathing or a shortness of breath or just a feeling that the breathing is not going right. There might be nausea or vomiting, and that can be hard to discriminate from just food poisoning. But if you're not sure, go to the hospital and get it checked. Ask, is this my heart? You might have sweating or dizziness. Some people think that heart attack pain, one of my patients said this to me in a way that really made sense to me. She said, I thought that heart attack pain would be something I couldn't stand, that it would be so bad that I wouldn't be able to take it. But she was having a heart attack that didn't feel like that. It just wasn't that severe of a pain. It's important to keep that in mind. Heart attack does not have to feel horrible. Next. This is the Hollywood heart attack myth. Heart attacks don't always feel like they look in the movies. Every minute counts. Don't hesitate to call 911 like so many women do. Women tend to get to the hospital on average 15 to 60 minutes later than men. Just go ahead. Go to the hospital. If there's a false alarm, we don't mind. Next. This is the American Heart Association's Don't Die of Doubt campaign, and these are common things that people say. I'd feel foolish calling an ambulance. Please get over that. That's what ambulances are there for. I didn't know driving myself to the emergency room would delay treatment. This is another thing. People who come in by ambulance get more attention because it's assumed that they knew something was wrong. You want to get the right amount of attention? Call the ambulance like you're supposed to. Next. How will the doctors decide if it was heart attack? Well, they'll do an EKG, but the EKG can be normal. This troponin blood test can find even tiny amounts of heart damage, but it might not be abnormal the first time. People may come to have that first blood test, it's fine, and they say, ooh, I'm in the clear, I'm out of here. Don't do that. You have to stick around because that evidence of heart damage may take an hour, 2 hours, 3 hours, even 6 hours to show up. So you're going to need to stay for a second blood test. I wrote here, remember that paramedic, and I just realized that I took that story out. I have a patient who's had multiple heart attacks. With her first heart attack, she was pretty sure something terrible was going on. She called EMS like she was supposed to. Paramedic came in, looked at her EKG and said, it's fine, honey. Don't worry, you're not having a heart attack. You must just be under some stress. So she stayed home, had her heart attack at home, lost heart muscle, and had a weakened heart from that. So don't listen to that paramedic. You can say, you know what, I'd really feel better if I go to the hospital. Women, especially younger women, are less likely to have this troponin value checked when they have chest pain. So that's why I'm telling you what it's called. You can ask for it. And you can say things like, how do you know I'm not having a heart attack? Can you show me the test that shows that? You have to sometimes really ask questions in order to get the very best care. Early treatment works best, so again, there's no time for denial. These images show an artery. Hopefully you can tell the difference, even with no medical training, between the left and the right. Arteries will be completely blocked, but during an angiogram or a cardiac catheterization, they can just go right in and use a wire to break up that blood clot and reestablish blood flow immediately. And then they might put in stents to hold that artery open. Next. This is one of the research studies we're doing. This is the Heart Attack Research Program. It's funded by the American Heart Association, and my special interest is in the heart attacks that are not the more common heart attacks. These are heart attacks with open arteries, and there are a number of different causes for it. I mentioned one to you, and that was that coronary artery spasm, but there are others. So we're using sophisticated imaging in order to sort that out. What is stroke? A stroke happens when blood flow to the brain is interrupted by a blocked artery or a burst blood vessel. Next. Symptoms of stroke are sudden weakness or numbness of the face, arm, or leg, especially if it's on one side of the body. There may be a sudden confusion, difficulty speaking or understanding speech. There may be sudden trouble seeing in one or both eyes, or sudden trouble with walking, dizziness, a loss of balance, or coordination, or a sudden, very severe headache with no known cause. Even if these symptoms are with you for a little while, but then they go away, you want to get right to the hospital, because you can imagine that blood vessel that could be causing a stroke, and you can imagine that blood clot and the body sort of breaking it down, and now the blood flow is reestablished to the brain, and you feel okay for a while. But the riskiest time is early, and that blood clot can form again, and the stroke can be permanent. Same is true with heart attack. If there's chest discomfort that you're not accustomed to, it's lasted 20 minutes, but then it's gone. You still need to come into the hospital because that early time is still risky. Next. Learning to recognize a stroke is important because time lost is brain lost. Stroke is a medical emergency, you call 911 for that. You don't call your family member to bring you to the hospital, you call 911, because particularly for stroke, the treatment must be very early. Next. Now let's talk about prevention. And we'll go through this pretty quickly, but it's really important. Next. These are the 7 things that you can do to prevent heart disease. There are many things we can't do. We can't change our age. We can't change our genes. We can't change some of the risk factors we were born with. We can't change our family, but we can change these things. Blood sugar, healthy diet, healthy weight. We need to get active, not smoke, have a normal blood pressure, and low cholesterol. And you might as well do it all. Next. Eating better, I advocate for the Mediterranean diet. And this is often plant-based, but I like to include fish or even some poultry in this diet. It's really healthy food, not processed food. Think about the things you should be eating without thinking so much about the things you shouldn't be eating. If I think about not eating cookies, all I want is a cookie. So think about making sure you're eating healthy vegetables, lots of vegetables and some fruit. Fish at least twice a week. The legume family, nuts, lentils, beans, chickpeas, any of those. And plenty of olive oil. Olive oil is a health food. You can have as much of it as you want. Treats are okay, but you can't have one of everything. So if you're having, well, I have one cookie tonight, and now tomorrow I had potato chips, and the third night I had ice cream, you look back and you're really not eating healthy. And takeout is a problem because takeout is generally not healthy. Fortunately, for those of us who live in New York City, there's almost always a deli that has some grilled chicken, grilled fish, and some healthy steamed vegetables if you need a fast meal. Eggs are controversial. I believe that eggs have healthy nutrients, so I advocate having up to 6 whole eggs a week and as many whites as you want. Absolutely no on margarine and vegetable oil. They don't raise cholesterol, but people who eat them are at higher risk of death from heart disease. Next. Get active. The more the better. We're aiming for at least 20 minutes of moderate activity per week. You'd like to do some weight training. Having your muscles be healthy will help regulate your metabolism, help control weight, and prevent diabetes. Sit less. During the pandemic, we were all sitting way too much. It happens to me too. Just get up. There's no reason that you have to be on camera every single second. And if you get up, other people will get up, and everybody in that meeting will be healthier. Next. Any exercise is better than none. This is from the Nurses' Health Study. And when we compare the couch potatoes who did absolutely nothing to people who walked just an hour a week, we see, if you click, a 12% reduction in the risk of heart disease. And the more exercise, the better. Next. Similarly, every cigarette somebody doesn't smoke lowers heart attack risk. If you smoke or you know a smoker, this is something to keep in mind. Every single time somebody doesn't light up, their risk of heart disease goes down. Quitting is the best, but going from 10 cigarettes to 6 cigarettes already cuts your risk of heart disease. Next. For blood pressure numbers, the normal is 115/75. A lot of people don't know that. That top number is the pressure when the heart beats. The bottom number is the pressure between beats. They're both important. Next. Normal is, again, less than 120 over less than 80. The higher the blood pressure, the higher the stakes to get it right. Next. This is a reminder to me that all of these things that are on this slide about eating healthy, moving more, having a healthy weight, they can all lower blood pressure, and so can limiting alcohol, by the way. But all of these are independent risk factors for heart disease. So if somebody is not active and then they get active, even if their blood pressure doesn't go down, their weight doesn't move 1 pound, their cholesterol stays high, they're still healthier because all of these things are independent. And I think about that with my women, especially with weight. I think that a lot of women are focused on maintaining a healthy weight. And if their exercise program or their diet program doesn't get that weight down, they feel like they failed. But that's not the right way to think about it. We're going for health, and health can be achieved in many different ways. Next. Little blood pressure lowering goes a long way. You can save lives in the doctor's office by just lowering blood pressure. Next. Blood pressure treatment is easy to take. The main thing I want you to take away from this is that it's important to take the medication every day, so tie it into something that you know you will do. And also, it's important to have a normal blood pressure. Once you're taking pills, you really want your blood pressure to be normal, and that's true every day. If for some reason you have side effects with your blood pressure medicine, talk to your doctor. There are over 30 choices for blood pressure. It should be pretty easy to get it right just by talking over what you're feeling. Next. There are 2 main types of cholesterol. There's the LDL cholesterol, that's the one that builds up in artery walls. And then there is, if you click, the HDL cholesterol, which is thought to help clear cholesterol out of the system, maybe. An important thing to remember here is they don't offset. Many people, even though they have a great HDL, may build up plaque. So ask your doctor about a test to look for plaque if you're not sure if you should be taking cholesterol lowering. I know the hour is late, so let's see if what we've got on the next few slides here. Oh, how do we decide if you should take cholesterol drugs? Well, anybody who's already had a heart event or stroke definitely needs them. If your LDL is 190 or higher, if people have diabetes and they're over age 40 and that LDL is over 70. But for many other patients, all we need to do is plug the values into this Risk Estimator Plus, which is easily available online. You can get your numbers and do this yourself. If your risk over the next 10 years is more than 7.5% of a heart attack, stroke, or dying from heart disease, you should be on cholesterol lowering. Next. I think this says the same thing. Target LDL is between 30 and 70. That's normal. And in fact, lower is perfectly fine. Even single-digit LDL cholesterols are great. Next. If you have diabetes, you're going to want to use not just medications, but also diet and exercise to control it. Muscle strengthening may be particularly important. Ask your doctor about the new medication classes that don't just control diabetes, they also lower heart disease risk and can even extend life. And those are those medication classes listed here. Next. Important in talking to your doctor, you're in charge of your health. Be sure that you get all of the things you're concerned about addressed. I find it's helpful when people bring a list of questions because I know that I've dealt with everything in the office when we're face-to-face. If you have to follow up with a question later, it's fine, but ideally bring them all to the visit. You need to understand all the recommendations. I lapse into jargon sometimes too. Ask. If you're not sure, please ask. Next. What else can you do? Learn CPR. CPR saves lives. If you don't know CPR today and you're on your way home and somebody collapses in front of you, when you call 911, the operator can tell you what to do. You don't need to do mouth to mouth. CPR is easy to learn and it's easy to do. All right, so what's the most important information for you to take away today? I know I gave you a lot. The most common symptom of heart attack and heart disease is chest discomfort, but it might not feel that bad, it might not even be painful, and it might not be in the chest. Next. Don't die of doubt. Early treatment works best for heart attack and stroke. Call 911. That's the best way to make a full recovery in case what you're feeling is heart attack or stroke. Next. There are 7 things that you can do to reduce your heart disease risk. Do them all. And next. Tell someone what you learned today, please. Heart disease is preventable and treatable, but it's the leading killer of women. I think that may be our last slide. Oh, lead by example. Bring your family with you. All the moms and grandmas out there, bring the children with you when you exercise. You're a role model. And I think that might really be our last slide. So thank you very much. And I'll be happy to take any questions in the next couple of minutes. You can just hit escape on you.
Harmony, thank you so much, Dr. Reynolds. That was fantastic as usual, unbelievable amount of information. I think I'm going to suggest to our audience that they go to the YouTube that gets recorded. They can listen to what you've spoken about in 1 hour. It'll take 2 or 3 and really digest it. I want to actually congratulate you on spending so much time on prevention, which is what these programs are all about. I mean, it's said that 80% of heart attacks and strokes are reversible. And I think if people follow the recommendations that you made and that we talk about all the time, we can really go a long way, and especially in women who don't realize how important it is that they focus on their cardiovascular health. So thank you for touching on all those issues. You're always doing a fantastic, amazing job, and I'm really grateful. We've got a few questions. Let's maybe just answer them very quickly. And then the questions I don't get to today, in our next program in March, we will take your questions and answer many of them in my panel that I'm setting up with several of our cardiologists at NYU. Just before the first question, I did see a question come up about somebody who wanted to come see one of our preventative cardiologists. And I'm going to just call out the number here, 212-263-7751, 212-263-7751. If you call, you can make an appointment with one of our preventative cardiologists. If it's something that you'd like to do, even if you have a cardiologist, someone asked me a question, they had a stent placed, they have an invasive cardiologist, but they'd like someone to get into the details on prevention, we're very happy to see you as a consultation. We'll work with your doctor. It doesn't mean that you have to become a permanent patient of one of our doctors. Harmony, in the next few minutes, maybe you can just quickly answer a few questions and then we can close it up.
I'd love to.
Are there any cardiac assessments? Oh, you can read it. Go ahead.
Sure thing. Are there any cardiac assessments that should be done at age 65 if a person has a history of heart disease in their family? Yes. You will want to get the simple stuff, your cholesterol checked, your blood pressure checked. You want to know your weight and your body mass index. But if you're in an intermediate area of risk and it's not clear to you or your doctor whether you need cholesterol lowering, for example, then one of the CT calcium score tests can be very useful in helping to make that decision. Dr. Goodman, anything to add?
No, I agree with that. And I think the important thing is get to the doctor and be checked. I think there's so many people running around with multiple risk factors and they don't realize that they're at significant risk. So go to a healthcare provider and get all these parameters checked. Next slide. Next question.
Do the arteries in women normally narrow with aging? Well, yes and no. More women at older ages will have some plaque buildup, and that's why I mentioned when you get the CT calcium score that you want to reference it to people your age, women your age, men your age. But it's not really normal for the arteries to actually narrow. Having a tiny bit of plaque buildup may be okay when you get into your 70s or 80s, but many people have more plaque than they're supposed to, and the arteries are never supposed to narrow. Dr. Goodman, anything to add?
No, it's been great.
How can we predict who will have a heart attack? These are those risk factors that we've been mentioning to you. They're not perfect. Not everybody who has heart attack will have any of those risk factors, and surely there are people who have all of them and get lucky. But we go with the percentages. So it's high cholesterol, high blood pressure, diabetes, being overweight or obese, having a sedentary lifestyle, not getting exercise is a major risk for heart attack. Smoking, and wait a minute, I'm missing one. Weight, diet, exercise, diabetes. Cholesterol, blood sugar, diabetes, that was it.
Yes, absolutely. So, and I think people should realize these risk factors are additive. The more risk factors you have, the more likely you are to have a cardiovascular disease. So it's really important that even if you modify 1 or 2, you can significantly reduce your risk. Next. So this is a question I think that I'll take, being an integrative holistic cardiologist, which is what I want to learn about Lipidine, which is marketed as an anti-cholesterol supplement. So just to let you know, Lipidine is actually a combination of a product called bergamot and hydrovas. Bergamot is from a citrus fruit that's grown that comes from a place called Calabria in southern Italy. And it has been shown to reduce cholesterol. And hydrovas is actually just an extract of olive oil. And we know olive oil is very, very good for cardiovascular reduction, as seen in the Mediterranean diet. In terms of this product, bergamot does lower cholesterol. I actually took it myself and it lowered my cholesterol 60 points. So it has ingredients in it that can lower cholesterol naturally. But I want to make the point, there hasn't been a study that I've seen on Lipidine. And you should know that these products are not alternatives to statins if a statin is indicated. It's something to talk to your doctor about. They are natural, they can't harm you, but I think it's something that needs to be discussed with your physician. And certainly people who need to be on a statin, particularly secondary prevention, where you've had a heart attack and stroke, this product does not replace that. And in people who actually are having trouble bringing their cholesterol down because you're on a statin or for any other reason, this can be very, very helpful. Definitely to be discussed with your doctor. And if possible, you can see someone who's integrative and holistic, and they'll know all about it. Next one. Last one, maybe you can take 1 minute, and this is a really good question. Someone's having heart palpitation. It's quite common, and doctors reassured somebody, but they're still having palpitations. What would you do about that?
It's important to know exactly what the palpitation is from. And I find it's helpful when explaining palpitation to people to just have them tap out for me what their heart feels like. And I can learn a lot just from people showing me what they feel. Sometimes there really is nothing to worry about. You might have extra beats or skipped beats. It's really the same thing. And those are incredibly common and normal. But then other palpitations can be a health concern. So I would say, just if your doctor said there's nothing to worry about, but you don't feel comfortable, then you need to go back and ask the doctor for more explanation about why, so that you can feel comfortable. That's the part of what the doctor is there for.
I would add just one thing. There's so many patients with palpitations that are really related to benign PACs or PVCs. And I have found this combination of magnesium and fish oil and CoQ10 to be very, very helpful. It's benign, and sometimes I see patients responding and they feel much better by just taking that combination of supplements for a few weeks. The most important thing is to rule out underlying structural heart disease. And once that's ruled out, you can feel safe that you're not going to have a heart attack or stroke, and they're not going to hurt you. Thank you so much, Dr. Reynolds. You are fabulous as always. I congratulate you on your incredible work that you do. And please keep up the good work, and please always find time to come back and talk to us. Thank you very much. And thank you everybody for listening. I look forward to seeing you at our next program. Thank you.